Ako ha?
Mamaya ako mag-a-admit. Sige.
Ay, ready. Uy, buti pa sila ganito.
Hindi kami ganyan ka.
Kwenta, girl. As in, text sa ni Doc PMK, let me in. And I'm like, putang ina, meron nga pala.
Hindi ko malala, di ba meron na niya bars? Hindi ko malala yung pas.
Ganito, kapag dumating na si Doc PMK,
Sino mag-ano?
siya. Kasi
Siya
siya
mag-
Hello?
Hello po, ma'am. Good afternoon.
Okay. Let's start. Are you all there? Mau is here from Makati Med. May mga taga St. Luke's. Are there people from St. Luke's? Can you please take a video? Please.
Yes, ma'am. We are recording po, ma'am.
Okay, sige, let's start. I'll share my screen. Ay, ano to? Ay. Is it full screen or not?
Ma'am, it's in the presenter's view po.
Sige. This one. Okay na?
Yes, ma'am. Okay na po.
Okay. All right. Good afternoon, everyone. I'm Dr. Patricia Ko. Today we are having our OBID rounds, which is septic abortion. Okay. So, all right. So this is our topic, septic abortion. Okay. And please listen because we will be having prizes. There will be a quiz. So in the Philippines, we know that abortion is illegal. Therefore, women who have induced abortions do it illegally. They do it clandestinely, not in a hospital setting. And it is estimated that the induced abortion rate was 27 per 1,000 women. This was based on a study conducted from the year 2000 to 2001. So it's high. And in the Philippines, the estimate is that there are 400,000 induced abortions per year, and more than 80,000 are admitted due to abortion complications. So that's very high. And in the world, there are around 19 million illegal unsafe abortions per year. And from the year 1994 to the year 2000, according to this study by Juarez and others, there have been large increases in induced abortion that were seen in Metro Manila and in the Visayas. This has been due to the increase in the rate of unplanned pregnancies. So the root cause of this is the inaccessibility to the population of modern contraception methods. And we know, just like now with COVID-19, public health becomes political. So in the issue of reproductive health, we know that modern contraceptive methods are dependent on who is in power. Therefore, it becomes a political issue, unfortunately. So this is my first question. If you want to win this gift pack from Alberta's Pride, snack pack with yummy snacks inside, what are the 3 most common symptoms of septic abortion? So please write in the chat box. Okay. Fever, pain, and bleeding. Okay, very good. But the pain is not very, parang hindi siya ganun ka-precise, no? So, I will give the prize to Dr. Nino Emocling, no? Because it was more precise, fever, bleeding, and abdominal pain, no? So, all right. Kala nga. I want to see, oops. All right. So the most common symptoms of septic abortion, hello? First is vaginal bleeding. Second is fever, more than 38 degrees. But what can be a confounder of fever? Sometimes if the woman used misoprostol, which is now the most common method of inducing her abortion, it can also lead to fever. So the fever due to misoprostol intake is not septic, no? It's because of the misoprostol. And then there's also lower abdominal pain or uterine tenderness. So those are the 3 most common symptoms of septic abortion. Afterward, there can be chills, body malaise, an elevated WBC count, and foul-smelling vaginal bleeding or placental tissues per cervical os. Okay. What are the signs of septic abortion? As mentioned, the temperature greater than 38 degrees Celsius, heart rate of 110 or higher per minute, respiratory rate of more than 24 per minute, lower abdominal tenderness, signs of severe sepsis, on internal examination, bleeding or foul-smelling products of conception, uterine tenderness, crepitation of the uterus or feeling that there's gas trapped inside the uterus when you do IE, or abdominal muscle guarding. So not all of these signs have to be present. Just the presence of fever plus leukocytosis, for example, is already enough to make a diagnosis of septic abortion. Next quiz question. What is the most common laboratory test result seen in septic abortion? Very good, leukocytosis. Okay, so the winner is Dr. Patricia I. Ann Franco. Okay, leukocytosis is the most common laboratory test result that we see if the patient has a septic abortion. Okay, so that's the most common sign, laboratory sign. We can also do a transvaginal ultrasound to confirm if there's a product of conception in the uterus. We can also do chest x-ray if we suspect that there is, for example, in cases of instrumentation. Sometimes some women, they have objects inserted in their uterus and this can lead to uterine perforation and also bowel perforation. So on chest x-ray with abdominal view, no, with view also of the upper abdomen, you can see a pneumoperitoneum. And this can also be seen on abdominal x-ray. So the gas from the bowels that have been ruptured can be seen on the x-ray, no, as a gas underneath the diaphragm. Sometimes we may need to do further imaging studies such as CT scan or MRI if we suspect abscesses. So these are in more severe cases. It's very important to also obtain swabs. So ideally, prior to doing internal examination and prior to giving the antibiotic, please do the cultures, no? So from the cervix, we can screen for gonorrhea and chlamydia, so we can check for, chlamydia, gonorrhea PCR or chlamydia antigen test plus gram stain to check for gonorrhea. From the vagina, we can obtain gram stain and culture studies, especially if the woman had instrumentation or she went to an abortionist. It will be useful to see if there are any pathogens in the vagina. From the endometrium, we can also obtain gram stain and culture to detect the pathogenic organism, including Clostridium perfringens, which causes gas gangrene of the uterus. And when we do culture studies, please obtain aerobic and anaerobic cultures. And if the woman is in septic shock, that means that she really already has widespread disseminated infection, blood culture will be very useful. We can also get samples for time, partial thromboplastin time, electrolytes, liver function test, kidney function test, if in cases of septic abortion. So what are the most common organisms that are seen in septic abortion? So these are most often polymicrobial infections. And the most common ones are the gram-positive cocci, especially the Staph aureus, especially if there has been instrumentation. Also beta hemolytic streptococcus. Gram-negatives are also common. The most common gram-negative is the E. coli. We can also see Pseudomonas infection. Anaerobic infection is also very common. We also have to think of STIs, concomitant sexually transmitted infections such as chlamydia, gonorrhea, bacterial vaginosis, etc. We can also think of Clostridium perfringens. And what about COVID-19? Does COVID-19 lead to a miscarriage, which can become septic? So at present, the preliminary data shows no increased risk of miscarriage and sepsis, septic abortion because of COVID-19 infection. But of course, further studies have to be performed. So the diagnosis of sepsis is based on infection plus a systemic manifestation of infection. So temperature is 38 degrees or higher, or the woman can also be hypothermic. She's prostrated, which means she's very weak, tachycardic, respiratory rate, tachypneic, blood pressure is less than 90/60, without other causes of the hypotension. She can have an altered mental status already. The WBC count is leukocytosis of more than 15,000 units per liter or less than 4 units per liter. CRP is more than 2 standard degrees above the normal value. And then the blood sugar can be elevated in the absence of diabetes. It's also very important to see the urine output because women with sepsis are oliguric with a urine output of less than 0.5 ml per kilogram for 2 hours even after fluid resuscitation, or a creatinine increase of more than 0.5 milligrams per deciliter. We can also see coagulation defects, no? INR of more than 1.5 or APTT of more than 60 seconds, and thrombocytopenia of less than 100,000 units per liter. So, severe sepsis, when a woman already has severe sepsis, then you can already see signs of tissue hypoperfusion, no? So, her end organs are already in compromise. or there's already sepsis-induced organ dysfunction. So if there's sepsis-induced hypoperfusion, there is hypotension that is induced by the infection. So even if you will hydrate her, her blood pressure does not go up. You will also note, high lactate and oliguria. Now, septic shock, there's already sepsis-induced hypotension with a systolic blood pressure which is less than 90 and a mean arterial pressure which is less than 70. So, last question in our quiz. What is the cornerstone in the management of septic abortion? What is the most important management if you have a woman who is already septic and she has an abortion? Let's look at the chat box. Antibiotic, hydration. Nobody answered. Sige na. Hindi nyo ba alam yung sagot? Evacuation. Correct. Dr. Toralba, Braille is correct. Okay? So, if you are the obstetrician, like the woman here in the picture, and then you see a woman who had her baby aborted. She performed an illegal abortion. She went to a hilot, and the hilot did the uterine massage and inserted some herbs inside the woman's vagina. And she comes to you bleeding and febrile, hypotensive, but the baby is still alive. The fetus is still alive. And then you are forced to evacuate the embryo, even though the embryo is still alive. So you feel so guilty because you will be killing the fetus. So are you liable? What do you think? Can you be sued? Can you go to jail because you will kill a fetus? You will perform abortion in a live embryo? What's the answer? Are you liable? Can anybody answer? Yung ating rotator. Ano? No, yes, no? So because we have to save the life of the mother. And the source of the infection is the embryo or fetus. So you are not liable. Because anyway, that embryo or that fetus, once the woman is septic, that embryo will not live anymore. No? The baby will die regardless of all the medications that you will give. The baby will die and then the fetus will be expelled. So you have to save the mother. Okay, so don't feel guilty because a woman who is already in septic abortion, there's no way that you will be able to save the baby, but you have to save the mother. Okay, so this is the cornerstone of management because the source of the infection is the product of conception. So you have to evacuate the product of conception immediately. Okay. So the most common way that we evacuate is to do DNC or curettage. If the cervix is still closed, we have to dilate the cervix, of course. Another very good way of evacuating is to do manual vacuum aspiration. This is using like a sterile plastic instrument to aspirate the product of conception. Of course, if the fetus is already big, that there are already bony parts, we really have to deliver the baby first before doing a DNC. But if this is there's no bony tissue yet, then we can go directly to DNC or to manual vacuum aspiration. And then before doing the DNC or the manual vacuum aspiration, also look for vaginal, cervical, and pelvic lacerations because most of the time there can be lacerations, especially if the woman performed an abortion herself. Watch out for uterine perforation because in septic abortion, the tissues are very friable. The uterus is also enlarged and thinned out. So if you're not careful, you can perforate the uterus. And it's important to vaccinate, give active vaccination against tetanus and tetanus immunoglobulin. So fortunately, although it's still unfortunate, most of the illegal abortions done now in our country are through the use of misoprostol. So because this is the preferred method of choice, we see less cases of septic abortion and less cases of tetanus infection and lacerations. But these can still occur. Of course, it's also very important to give the appropriate antibiotics. So this is your answer was also correct, no? Antibiotics. This is also a cornerstone. Okay? So remember to give broad spectrum antibiotics. It is preferred to give antibiotic combinations rather than monotherapy and give it prior to the evacuation, so loading dose of the antibiotic before evacuating the product of conception, and ideally before but ideally you have to um, obtain the culture studies and obtain the laboratory tests before you give the antibiotics. Okay? So preferably you have to give the antibiotics within 1 hour after the diagnosis of septic abortion. According to a Cochrane collaborative trial where they analyzed 3 randomized control studies, but these studies were done more than 30 years ago, involving 277 women with septic abortion, the antibiotic of choice, they compared penicillin plus chloramphenicol versus clindamycin monotherapy. And they concluded that there was no statistically significant difference between the two groups in the length of the resolution of the fever. And they noted that actually the clindamycin group had more adverse events such as pelvic abscess and the rashes, also diarrhea, but the adverse events associated with clindamycin was not statistically significant. So these are the choices of antibiotics that we can give. Of course, we can also give other kinds of antibiotics, but these are the most common ones that we give. Usually, we give either AMPI plus penicillin, and then we can also give gentamicin plus metronidazole, no? So triple therapy discovers already gram-positive, gram-negative, and anaerobes. Plus, this is not expensive. However, of course, we have to give so many doses, so many drugs, no? Triple therapy. Another common antibiotic regimen that we give is clindamycin plus gentamicin, and we can also add ampicillin. So gentamicin is very good also because this will cover clindamycin for anaerobes plus gram-positive, gentamicin for gram-negs, and ampicillin for gram-positive organisms. However, watch out for ototoxicity, and also if the woman already has a compromised renal function, be careful with the administration of gentamicin. Now, before, when I was a resident, chloramphenicol was a very common antibiotic. It is very cheap and it is very effective. So as was mentioned, I mentioned earlier, chloramphenicol is very effective. It's given with penicillin. However, I think this is already out of circulation. It is no longer available in the US and I think even in the Philippines because of the risk of um, aplastic anemia, no? So the risk of anemia, thrombocytopenia, and also leukopenia, no? With chloramphenicol and the gray syndrome, syndrome, but this is more commonly seen among infants. But this is good to know because maybe one day if we have a lot of antibiotic resistance, maybe chloramphenicol will fall back into favor. Now, sometimes you have to give the carbapenems as monotherapy, either imipenem, meropenem, or also the piperazoline tazobactam. So these are also very good, and we research for the more severe septic cases. Now we go briefly into the management of sepsis and septic shock. So we have to act fast. The goal within the first 6 hours is to attain a CP of 8 to 12 millimeters mercury, mean arterial pressure of greater than or equal to 65 millimeters mercury, urine output of at least 0.5 milliliters per kilograms per hour, and then the oxygen saturation of at least 70%. Remove the source of infection rapidly. Okay? And then give antibiotics within IV antibiotics within 1 hour of diagnosis of the sepsis. So we prefer empiric combination and broad spectrum antibiotics. If the woman is hypotensive, we give fluid resuscitation. We can give as much as 30 ml per kilogram IV crystalloid fluid to be given fast in the first 3 hours. So usually we can give 1 to 2 liters of IV crystalloids. However, watch out for congestion. No? In case that very high volume of crystalloid is needed, then we also have to give albumin in order to prevent congestion. Now, if the woman is still hypotensive despite IV rehydration, then we already have to start vasopressors to achieve a target mean arterial pressure of 65 millimeters mercury. The first choice is norepinephrine. If added vasopressor is needed, we can give vasopressin or epinephrine, and it's also very good to raise the legs. And then we monitor the lactate levels because this will indicate if you are managing well the septic shock. So try to normalize, maintain lactate levels to normal values. And then again, as I mentioned, get the culture study. So it's very, very important to get the cultures before initiating the antibiotics. And don't forget the antimicrobial stewardship that we have been hammering into you, that once the CS results are in, we can already start narrowing the antibiotics. So instead of giving the ampimetrogenta or the piptazo, once you know what organism is causing the sepsis, we can already tailor the antibiotic, no? So we don't have to give the very strong IV antibiotic for 7 days. But we still have to give the antibiotic uh, to continue the antibiotic, no? To finish 7 to 10 days. Now, in case of sepsis or septic shock. So if the woman is septic, then you really have to give the antibiotic for a minimum of 7 days, but it can already be de-escalated. And we have to continue the antibiotic until the patient is asymptomatic for at least 48 to 72 hours. And we have to reassess daily regarding the choice of antibiotic, because if we can already de-escalate or stop the antibiotic, then we can already do so. Now, corticosteroids, because this is infection, generalized infection, we rarely give corticosteroids. We only give it in sepsis if the fluid resuscitation and the vasopressors don't work. If the woman is already in ARDS and she has to be intubated, then a prone position is also very useful, no, to raise her oxygen levels, just like in our COVID. Maintain good glucose control. Now, regarding nutrition, if possible, enteral feeding is still preferred compared to IV parenteral nutrition, which is more associated with also with infection. And set goals of care. So within 72 hours, if the woman is admitted in the ICU, we have to talk to the family and manage and to explain to them what's happening to the patient, set their expectations, and address the goals of care. So that's it. So thank you so much. I hope you learned something, and if you have time, you can attend the POG's webinar, which will be on Saturday, Emerging Issues in Adolescent Sexual Health, and I will talk about catch-up vaccinations for women. Thank you. Do you have any questions? Or would you like to share? Doktor, yung mga ano natin, residents sa East Ave, can you share a case? Did you have recently cases of septic abortion?
Good afternoon, ma'am. Recently po, I have a patient at the ER. She came in po, the patient came in po, hypotensive with history po of fever. And then upon history po, she was instructed by her friend to took four pieces of misoprostol per oral, and then to insert another four pieces of misoprostol per vagina. Then after that, she had profuse vaginal bleeding with meaty vaginal discharge po. And then she claimed po, Doc, na the there was a package. It was combined with another medication po. She was not familiar of the name of the medication, but her friend told her that it is used to stop the bleeding per vagina. Then we asked her to describe the pill. Then we thought that it is Metergine. I think, Doc, they have her friend has a package po. It is misoprostol plus Metergine. And
Ah,
then, opo, Doc.
so was it septic abortion or induced abortion that is not septic? And then she just became febrile because of the misoprostol. What do you think?
I think, Doc, she was febrile po prior to intake po of misoprostol.
So it was really a case of septic abortion, septic
Yes
induced
po.
abortion.
Yes po.
Why did she have the infection? Ano kaya? What is the cause? Did she also do something else that, like, some would even insert catheter or instruments inside the vagina through the cervix in order to induce an abortion? What do you
She denies po any kind of instrumentation. However po, because she keeps the her pregnancy from her family members, when she had fever, her mother po asked for a hilot. Then they manipulated the hypogastric area of the patient po.
Okay, all right. And what happened to the patient? So what did you do? Did you admit the patient? What happened to her later on?
At first po, upon arrival at the ER, we stabilized first the patient. We we put double line to administer fluids to increase her blood pressure, and then we administered medication po to stop her bleeding. We gave her oxytocin and tranexamic po.
Mm.
And
So
then,
an
yes, doc.
incomplete abortion or completed abortion already?
It's still incomplete po, ma'am, because on internal examination, there are still blood and blood clots with placental tissues po
Mm-hmm.
on IE,
Okay,
and the cervix is open po.
I see, I see. Okay. So did the patient recover?
Yes po, ma'am. She already went home po.
I see. So, yes, you're correct, no, that you inserted the double line immediately because she was already in shock. So it's good that the patient did not die. So even in these cases wherein there was no history of instrumentation, or probably there was instrumentation but the patient denies it, sepsis can still occur. So maybe the patient is not telling the truth. Maybe she went to a midwife where they did multiple IEs, and also maybe they also have coexisting sexually transmitted infections, or also UTI, which can also lead to sepsis later on. Okay, so that's really very common, and but it's good that you were able to manage her well. So it's also important to teach them how to prevent pregnancy the next time around. So did you advise the patient, regarding the dangers of doing illegal abortion and what she should do to prevent a pregnancy in the future?
Yes po, ma'am. We advise her to have family planning po. We inserted a ethanol subdermal implant po for her.
Okay, very good, no? So because even though we can get mad at these patients that they were not more responsible, but sometimes they just don't have access to proper contraception. So we also have to help them. Okay? What about Dr. Mau Manzano from Makati Med? Did you already encounter a case of septic abortion?
Hi, Doc. Actually, in Makati Med, we don't get a lot of cases of septic abortion. However, there was one time we had a walk-in patient who came in febrile, with hypogastric pain and vaginal bleeding. Upon examination of the patient, there was a catheter. There was a transcervical catheter on speculum examination. So at the time, we admitted the patient, we administered antibiotics, and then the patient was brought to the delivery room for curettage po. However, due to problem with finances, the patient also left the hospital after post completion curettage.
So was the baby still alive when the patient arrived, or was it already an incomplete abortion? Was she already bleeding a lot?
She was already bleeding, doc, and then no fetal heart tones appreciated. We also did an ultrasound prior to the completion curettage, and there wasn't any heartbeat.
So were you able to take a history of the patient who inserted the catheter? Where was she? Where did she go?
She went to a clinic in Caloocan, doc.
I see.
And then she was so the catheter was inserted, and then she was given a pack of medicine. There wasn't any label on the pack, doc, but it looks like there was some antibiotics also and methergine.
So they really know how to, I guess it's very common because they already have packs. And usually these patients, they will never disclose where they got this illegal abortion because they're also protecting those abortionists. Yeah. Because these abortionists are operating outside the law, no? They're doing illegal practice of medicine. Okay, so but did the patient survive?
Yes, doc. No other problems aside from fever. The other vital signs were stable at the time naman.
So she was not hypotensive. She was not in
No, doc.
sepsis yet. I see.
No,
So
doc.
just beginning sepsis.
Yes, doc.
I see. But it's my first time to, because in all my years of practice, I never saw an induced abortion with the catheter still inside. So yeah, it's unusual. So for me, actually, I had an interesting case in Makati Med. It was also a walk-in patient. She was febrile and hypotensive, so it was an induced abortion. Um, and however, the cervix was still closed, but she was already bleeding, and the embryo was still alive, but the fetal heart rate was already tachycardic. So I felt very guilty trying, if I have to evacuate the product of conception. However, the woman was already in septic shock. She was having desaturation. Uh, the O2 sat went as low as 80%. So we had no choice but to evacuate the product of conception and to give antibiotics. And she was even admitted to the ICU because she developed ARDS, but fortunately she survived. Yeah. So, but she never came back for follow up because she wasn't able to pay the hospital bill. But at least the woman survived. So yeah, so that's it. So that's my story. So it was very unforgettable. Okay, so what else? Any announcements? Wala naman. So did the interns learn anything? Kaya very important if you're going to be, as doctors, it's important to teach our patients family planning because we know that family planning resources are incomplete. Not all,
Canada.
sorry, not all hospitals and centers offer family planning services. So we have a duty to teach our patients how to prevent unwanted pregnancy. Okay, so now I will give the floor to uh, Alberta's Pride, who is our sponsor for today. They donated 3 yummy gift packs. So thank you. And there will be a very short product presentation. Okay, thank you.
Yes, thank you, Dr. Patricia. Good afternoon, doctors. I'm Shaila Candelaria from Alberta's Pride. Area ko po is Makati and St. Luke's. So, present ko na po yung gamot namin. Hingi lang sana ako. Yung Polymax po namin, yung Iron Polymaltose Complex plus folic acid. Syempre, 100 milligrams and 550 milligrams na folic acid. Less side effects po siya compared to other ferrosulfate in the market. Only 19 pesos and 75 cents. And yung calcidin po namin na calcium food supplement namin is 1,500 milligrams calcium carbonate plus vitamin D3. And yung folic acid po namin na Folladine, one of the smallest pure folic acid in the market, Folladine. And syempre po yung Obivit Max namin na food supplements, 16 vitamins plus minerals po. And yung Dalamax namin na clindamycin 300 milligrams capsule po for your patients with gynae infections. And also yung Fertimax namin, the first line infertility pill, 50 milligrams tablet po siya. So, ayun lang po. Available po kami, Mercury Drugstores and Watson's po. Thank you, Dr. Patricia.
Thank you. So is that it? Wala na kayong video presentation?
Wala na, Dr. Yun lang po.
Sige. Okay, thank you very much. And next time uli sana, huwag kayong magsawa. Thank you so much for sponsoring our infectious hour. Okay?
Thank you po.
Thank
Ingat
you.
po lahat.
And then, so thank you everyone. Next week, we will have another OB-IDS hour. And then I will be sending your gift packs, no? So, the winners are Patricia Ann Franco, Brian Turalba. Sino yung third? Teka lang. Who's the third one? And yung pinaka-last, si Brian Turalba. Oo. Nino, yes. Nino Emocling. So, are you all from East Ave? So,
Yes, Doc.
Patricia Ann, Brian, and Nino are all from East Avenue. So, I will be sending your gift packs. And then, the winner last week, sino nga ba? I will also send at the same time. Ha? Meron tayong winner last week, hindi ko pa nabigay. Yung winner last week was also from East Ave, right?
Yes, Doc.
O, sino nga ba yun? Yung Guerlain Beauty Pack.
Justin Gervero po.
Justin Gervero. O, sige. Babae siya or lalaki? Anyway, pwede
Girl
rin
po.
pang girl. O, sige. Okay. So, thank you and hope to see you again next week. But yung mga rotator ng Makati Med and also East Ave, can you please stay behind? We will just have a very short meeting. Thank you.
Thank you, Doc.
Thank you. Okay, so our rotators, pakita nyo naman yung mga face nyo. Mau, isang meeting na lang for all of us, ha? Okay, so you are, sino ba to? From East Ave, right? So, sige. Can you introduce yourselves?
Good morning po. Ay, good afternoon po, Dr.
Yeah.
Malay po. I'm Barbs Reyes po,
Ah,
second
your
year.
Barbs.
Yes
Okay.
po, ang staff.
What's your year level, Barbs?
Second year po, Doc.
Second year. Okay. And then the other rotator is sino nga ba?
Me po, Doc.
Ah,
I'm
What-
Rachel Valiente po, Doc.
Rachel? Okay. Hello.
Hi po.
I will be sending an email of yung what I will require in your rotation. So I will email it to you, no? Yung how you will present, because you will present in one of the conferences, no? Yung the rounds that we have. Also how you will refer patients. Okay? And your logbook. Okay? And
Yes po, ma'am.
question, no? So I will also send to you the email of what are the expected, what is expected of you. So Mau, can you introduce yourself also to the other East Avenue editors?
Hi po, Mau Manzano from Makati Med, third year OB resident.
Okay, sige. So I'll also send to you the requirements. So actually, it's not a difficult rotation. I hope you will learn something from it. I expect you to refer mga OB infectious cases properly, to present once, at least once, in one of the OB-ID rounds, and to have a logbook. So it will all be included in what I will email to you. Yung mga cases that you see in the OPD, in the floors, in case of referrals to OB-ID. If you encounter cases that are interesting, where you want to do cryosurgery, also colposcopy of yung mga suspected na HPV, or patients with genital warts, and then we have to do colposcopy of the cervix because it's also required in your in PBOG. You can call me and then we can do it. Okay? Because that's required. And is the OPD open? Mau, are you allowed already to do face-to-face in the OPD?
Not yet, doctor. We're still doing telemedicine.
I see. But once that you can do OPD rotation, I will teach you how to do the KOH smear, the wet mount, di ba? Yun. All right. So just tell me, do you already know how to do that? Yung wet mount, KOH smear? Mau, do you already know how to do a wet mount? Or baka naman marunong ka na.
In theoretical lang, doc, but we don't usually apply it in the OPD, though.
So it's an nice skill to have, and it's also part of the requirement. Okay? So once that you are allowed to do face-to-face, please inform me so we can have one session together. Also in East Avenue, Rachel and ano ang name nung nakalimutan ko yung name nung isa, wala yung name
Po,
nun.
Doc.
Are you already allowed to go to the OPD?
Yes po, Doc.
Ah,
Every Monday to Thursday po, Doc, nag-OPD po kami.
o sige, siguro next week I can pass by and we can have a session of yung kailangan complete yung mga gamit, no? Yung slides, microscope, the KOH, NSS, tapos may mga patient tayo. O di, that's also the day that I will give yung mga gifts dun sa mga nanalo, ha? So next week na lang kasi I'm busy this week.
Yes po,
Okay?
Doc.
And then if you have cases nga, yung mga genital warts, yung mga HPV, tapos we have to do colposcopy, you can refer to me and we can do the colposcopy. Okay? Yeah. O yung mga meron na ba tayong cryosurgery? Yung for cryosurgery, yung for, ano ba tawag dito? Colposcopy with yung nitrous oxide. Yung mga chronic cervicitis. Pwede kasing colposcopy pagkatapos cervical punch biopsy and then after cryo. Pwede rin natin gawin yon in case you have those patients, okay? All right. So do you have any questions?
Mga naman po, Doc.
Sige. What else? Meron kayong ni-refer, yung sino ba nag-refer sa akin? Yung Hansen's disease, pregnant, 6 weeks pregnant with leprosy, right?
Yes po, Doc.
Anong appearance nung leprosy niya?
Sorry, Doc, I was not able to take a picture po of the lesion po, Doc. Pero on examination, Doc,
Present mo para marinig din ni Doktora Manzana kasi very interesting yan eh.
sige po, Doc.
Sige, present mo.
We have a 31-year-old, a case of a Gravida 3 para 2 2002, pregnancy uterine at 8 weeks and 3 days age of gestation, to consider threatened abortion, Hansen's disease, lepromatous leprosy in relapse. Patient is a known case po of Hansen's disease, lepromatous leprosy since 2018. She was started on multi-drug therapy, Doc, rifampicin 300 mg per cup, 2 tub once a month, clofazimine 300 mg per tab on day 1, then 50 mg per tab once a day for days 2 to 28, that's February 19 to 26, 2018. In reaction, Doc, on February 5, 2019, and treated on April 10, 2019. She went into relapse on July 23, Doc,
What do you mean by
2020. And she was,
relapse? Anong nangyari? Bakit relapse? What happened?
Doc, the patient po, Doc, was treated po, ibig sabihin, Doc, nagkaroon po, Doc, ng, ang tawag doon? Yung, nagamot siya, Doc, pero nagkaroon po ulit siya ng recurrence po, Doc, ng lesions, Doc.
Ano appearance ng mga lesion?
Doc, nag-start po siya, Doc, as hyperpigmented plaques po and nodularities po on her skin po, Doc.
Okay.
Then, Doc, she was again started po, Doc, on multi-drug therapy. On interim, Doc, patient was asymptomatic na po with no new lesions. Until 4 days prior to consult po, the patient noted an elevation po again on her right arm associated with tenderness, 5 out of 10, no other associated symptoms. She sought consult po at our outpatient department in dermatology, and their plan is to continue the multi-drug therapy, Doc, rifampicin and clofazimine, and give paracetamol 500 mg, Doc, for 7 days.
For what is the paracetamol? Is
For
that part of the drug regimen for Hansen's disease?
It's not part of the drug regimen, Doc, but it would cover po for the pain po of the patient.
Pain. So she's in severe pain or mild pain only?
Mild pain only, Doc.
Oh, okay. Sige. Because I don't have any experience with ano ba yun? Clofazimine in pregnancy, and she's in her first trimester. And when I read about it, there can be hyperpigmentation of the baby. And also, ano pa ba? Meron pang ibang side effect yata ang clofazimine. So, can you ask dermatology if there's another alternative drug? Or is that the only drug? Or is there a possibility to give the clofazimine once she enters the second trimester?
Doc, according to Derma Service, Doc, it is still recommended po, Doc, that the patient takes the multi-drug therapy po, Doc. Kahit po category C po siya, Doc.
Talagang wala silang mabigay na ibang alternative.
nagbasa din po ako do kanina regarding kanina ng mga literature po. Ang sabi naman po Dok, kahit daw po category C yung drug Dok, yun lang po yung pwedeng mabigay sa patient Dok, and kailangan po siyang the benefit outweighs the risk po Dok. And usually naman daw po Dok, walang ganong side effect po siya Dok sa fetus po Dok.
Talaga, ang nabasa ko kasi is hyperpigmentation of the baby eh. Intense hyperpigmentation. So, wala talagang ibang alternative medicine. And it really has to be given now. Hindi pwedeng i-delay until after 12 weeks.
Hindi po Dok. Pero i-clarify ko din po Dok sa dermatology po.
Itanong mo, and then I'll read up about it because I've never handled a pregnant patient with leprosy, with active leprosy, no? So, yeah. So make sure that you have all the documentation, you have pictures, basta with patient's consent, because this is a very interesting case. Kasi yung leprosy ngayon is very rare. We can learn about it, no? Okay? Kasi you can present it as an interesting case, okay?
Yes po Dok.
Okay, sige. Thank you.
Thank you
That's
po.
all. Sige, bye-bye. Thank you.
Bye
Good
po
night.
Dok. Thank you po.
Thank you, Doc. Thank you,
Bye-bye.
Doc. Bye, Doc.